Consent Form 1. Name of proposed procedure or course of treatment: laparoscopic salpingectomy or salpingotomy after confirmation of tubal ectopic pregnancy. 2. The proposed procedure: describe the nature of laparoscopy and salpingectomy or salpingotomy. The laparoscopic approach is preferred to an open laparotomy procedure unless the patient is hemodynamically unstable or either suitable equipment or surgical expertise is not available. Salpingectomy is the preferred surgical option with the possible exception of a diseased or absent contralateral tube. Explain the procedure as described in the patient information. Note, if any other procedures are anticipated, these must be discussed and consent obtained. 3. Intended benefits to remove the ectopic pregnancy if it is confirmed by laparoscopy. 4. Serious and frequently occurring risks. It is recommended that clinicians make every effort to separate serious from frequently occurring risks. Women who are obese, have significant pathology, have had previous surgery or who have pre-existing medical conditions must understand that the quoted risks for serious or frequent complications will be increased. 5. Serious risks include damage to bowel, bladder, uterus or major blood vessels which would require immediate repair by laparoscopy or laparotomy. Uncommon, however, up to 15 of bowel injuries might not be diagnosed at the time of laparoscopy. Failure to gain entry to abdominal cavity and complete intended procedure laparoscopically, requiring laparotomy instead. The overall risk of serious complications from diagnostic laparoscopy is approximately 2 in 1,003 to 8 women in every 100,000 undergoing laparoscopy die as a result of complications. Very rare. 6. Frequent risks include inability to identify an obvious cause for presenting complaint: bruising, shoulder tip pain, wound, gaping wound, infection, persistent trophoblastic tissue, when salpingotomy performed. 4. 8 in 100 hernia at site of entry. 5. Any extra procedures which may become necessary during the procedure: laparotomy, salpingectomy, repair of damage to bowel, bladder, uterus or blood vessels, blood transfusion, oophorectomy. 6. What the procedure is likely to involve, the benefits and risks of any available alternative treatments, including no treatment. 2. 8. 10 insertion of a laparoscope through a small incision to confirm the presence of the ectopic pregnancy, following which additional instruments may be inserted through 2 additional small incisions to remove the tube containing the ectopic pregnancy. Expectant management is a useful form of treatment management for ectopic pregnancy in selected cases. It is, however, only acceptable if it involves minimal risks to the woman. Expectant management should only be used for women who are asymptomatic with an ultrasound diagnosis of ectopic pregnancy, with no evidence of blood in the pouch of Douglas and decreasing serum hCG levels that are lower than 1000 IU length at initial presentation. In women with an early ectopic pregnancy who are stable, treatment with a single intramuscular injection of methotrexate is often successful without recourse to surgery. Women most suitable for methotrexate therapy are those with a serum hCG below 3000 IU length with minimal symptoms and no fetal heart pulsations visible. About 14 of women will require more than 1 dose of methotrexate and fewer than 10 of women treated with this regimen will require surgical intervention. Persistent trophoblast is detected by the failure of serum hCG levels to fall as expected after initial treatment. It is primarily a problem occurring after salpingotomy rather than following salpingectomy. Although, even in the presence of persistent trophoblast, hCG levels may return uneventfully to normal. Cases of delayed hemorrhage owing to persistent trophoblast have been described, and this provides the rationale for following women with serial hCG measurements after treatment and administering methotrexate if levels fail to fall as expected. 7. Statement of the patient: procedures which should not be carried out without further discussion. Other procedures which may be appropriate but not essential at the time should be discussed and the woman's wishes recorded. 8. Preoperative information: a record should be made of any sources of information such as ROG or locally produced information leaflets given to the woman prior to surgery. 9. Anesthesia where possible. The woman must be aware of the form of anesthesia planned and be given an opportunity to discuss this in detail with the anesthetist before surgery. It should be noted that with obesity there are increased risks, both surgical and anesthetic risks. Both